Thank you so much for the session, and we have a little bit of time before we go to lunch to work through the questions on Slido. So if you have questions, I'd ask you to please make sure you jump onto Slido and pass them on there. We have quite a few questions for Paolo regarding Tecar. If I could summarise, the central theme seems to be around Tecar therapy has been around now for quite a long time, but we didn't see any evidence in regards randomised controlled trials or comparing against placebo. Is there anything you'd like to... is there such evidence? Can we say that this is something that's backed up by randomised controlled trial evidence, or at the moment we're still at case reports?
I don't hear.
The question relates, the questions, a bunch of different questions are saying, is Tecar therapy, now it's been around for a long time, do we have any evidence that it works better than placebo in a randomised controlled trial?
Yes, there are a lot of articles that speaks about this. Tecar therapy is still controversial in a lot of situations, so we can find articles where the results look similar to the placebo, and other articles where we can see that the effects are better than placebo in acute and in chronic pathologies. Unluckily, it looks that is a lot of years, because it's about 30 years that we know this kind of therapy from 1995, but the number of research are still quite limited, mainly because in the first 15-20 years was developed this therapy just in Spain and then in Italy. There are the two countries where there are more, is still more used. For example, I was in China for a lot of years, and there until 4 or 5 years ago it was almost unknown, the therapy. We could see just the devices in the exhibitions because of the producers, because we know where a lot of the manufacturers produce. But the evidence, I decided to bring just one study that I showed before during my presentation with that was not a comparison between the placebo, but I can provide different articles that I have where it's shown that it works. This just for the quick answer on the straight on the question.
Thank you. We have a question regarding EPM, in particular here in Switzerland. Are physios allowed to use this, or is this a doctor-only treatment, or what's the status for that?
The physiotherapist in Switzerland can use the needle. Also can use the electric current, and then it may be better if the physiotherapist before have the dry needling, shawl, and then the physiotherapist can use this methodology in Switzerland.
Keep the questions coming in. We've got a couple of minutes before we move on to lunch. Oh, sorry. Oh dear. You guys can jump on and see some of these questions as well, and I'll see you after school, Karam. Yeah, it's important for us, obviously, to keep an open mind, but not allow us to have an empty head with this regard. The effect of PME on tendon pain from Angelella asks whether this is superior to manual therapy or hands-off pain in decreasing techniques, for example, comparing to something like repeated isometric contractions.
Sorry, I didn't understand quite well what you said.
Yeah, I did a bad job of reading that out, I'm sorry. So the effects of PME on tendon pain, do you think they're superior to manual therapy or other treatments aimed to decrease pain, such as isometric contractions? So would you use that instead?
I think, yes, in clinical practice you see this strong analgesic effect. It's it's quite astonishing in my opinion. But again, as I said in the presentation, but I didn't have the time to talk about that in deep, we really have to be careful about this effect because the patient has the impression everything is well because the pain is away, but that's not the case. And it doesn't replace, again, the manual therapy. We talked about EPM, but we didn't talk about neuromodulation. When you are facing like a tendinous problem with associated muscle contractures, most of the pain comes also from these muscle contractions, and well, you address this kind of pain much better with the neuromodulation, and there is definitively Emanuele that can say more about it, and then you can achieve a strong analgesic effect with a manual therapy. I'm not aware of any data comparing the two techniques, but yes, you can have a lot of analgesia.
So another one from the audience. When do you use it most now after the experience you have? You use it more for tendinopathy or for intramuscular lesions? How would you say in percentage?
This is a good question. But the therapy is born for the tendon. We have a good result in the tendon when the gap is not big. When the gap, the hypococcygeal area is small, between 3, 4, 5 millimeter, we have the good result. In the last 7 years, we started to apply also this technology in the muscle injury, acute and chronic, and we have the good results. They have not study. We have one article, cases report on a little study, but the clinic effect is very, very good for above all for the quality of the scar, because after this technology we can charge before the tissue. Also we have less ricadute residue. But clear, with Ambri, we started now 5 years ago to apply this technology. It's not only the galvanic current, because in the muscle injury, we combined the other current. We combine with the microcurrent. Microcurrent is very important for the edema around the area focal primaire. And then also we combine with the neuromodulation, or it's very important, always with the exercise, the therapeutic exercise. This is the methodology.
And maybe to get back to the question you posed, because it was not clear if I have to answer it or Emanuele. Well, the patient's ECs and then we as a doctor see are quite different. Normally he already has patients that are quite triaged, so his case are surely different from ours. From my experience as a sports medical doctor, it's mostly the chronic, because they are also much more frequent in our practice than the acute traumas, fortunately.
Yeah, and I think the message was clear. You have to get the right formation, so you have to finish or have finished the dry needling course, and the ultrasound technique you should be good in to place the needle right.
I think it's really important. Again, it's the technique. As you saw, it's quite extensive, protocolized for any region. The anatomical description as well, and again, the basic is the sonoanatomy knowledge. And I'm not exaggerating when I tell you that I learned a lot from the physio doing ultrasound from my experience as a medical doctor, because since he's doing that every day. The sonoanatomy knowledge that that Emanuele has, and the physio that did this formation have, it's quite impressive. And as you mentioned, Patrick, also the knowledge with the needle, placing the needle at the right spot at the right time is it's not something you learn in one day.
Very well said. I mean, you know, the older you get, the more painful exams are. So for all the sports medical doctors, if you do the ultrasound, musculoskeletal ultrasound title, it's painful, especially the exam at the end. That's also a message to all the physiotherapists in here. Dry needling, you have read the position paper of your society. If you do it, you should have all the courses and the exam.
We have two questions here regarding femoroacetabular impingement, FAI or FAI syndrome. One is asking if you could specify the clinical presentation in regard imaging, and the other is talking about the treatment. So if you could go into the specifics of the treatment, the duration and so on.
Maybe I talk about a case, and then I let Emanuele tell you what he does when he treats this pathology. Well, when you have femoroacetabular impingement, I'm no orthopedic hip surgeon, so I'm not expecting to tell you all the details. But normally you have bone anatomy that's perturbed, that's causing this conflict. Mostly this conflict happens on the anterior part of the joint. And what you see when you perform ultrasound on this patient is an hypertrophy of the capsule on the anterior part, on the iliofemoral ligament, and that's not that often. Then, well, these patients are quite tricky to treat. So you can do mobilization, stretching, but they still have pain. Well, we know something about that with ice hockey players. It's quite difficult to treat them. It's not that often that they also get injection with corticosteroids, which, well, I don't know what your experience is, but it doesn't work that well as well. And especially if you are in season and you have a patient, an athlete that wants to perform and well, probably is going to do surgery end of the season. What can you do for him? What can you, if he wants to try to keep on playing? And there, I think we have a pretty strong therapeutic option. And I let Emanuele tell you what he does in these situations.
When the patients have problem in the hip, we see often in the hockey player, this is an interface between the iliopsoas and joint capsula. This is an arthritis area, and then we can see in the ultrasound this is hyperechoic tissue, and then normally this hyperechoic is near to the capsula. In the capsula we have a lot of nociceptor, and the patients feel a lot of pain when you bend the hip. Then we go with the ultrasound, with the needle ultrasound guided, and we apply the galvanic current. The galvanic current causes, sure, we have a neuromodulation. We can stimulate the nociceptor alpha beta, and the alpha beta is very important to get the gate control. Because close the stimulin entry to alpha delta. Also, we can stimulate the Faber-C for the mechanism of descendant inhibitories in the pain. And then normally it's enough one time, and it's good to say for the invasive therapy for one changement is enough one treatment normally. This is we can if after 1, 3, 4 session the patient have not an improvement, or is the therapist, or is not the therapy for the patient.
But also, you mentioned the neuro inhibition, but it's also the capsule itself that gets that's no longer as stiff as it was before. There is easier to compress. It's not that rare that they come back 1.5 months to 2 months later, but you can repeat that. And again, it's not a definitive treatment, and we recognize that. And but it's surely a strong effect. And well, I would be an athlete. If I would be an athlete like that, I think I would go for that instead of a corticoid injection, especially when we think about possible side effects.
We heard it from the speaker before, there's no one fits all. So how do you decide? I mean, we know it from Achilles tendinopathies. Sometimes the Achilles tendon is completely normal. It's more the tissue around which is the problem. So how do you decide? You're using EPM, using shockwave therapy, using PRP. Nobody is using corticosteroids, we know that. I hope so. How do you decide?
I think there is still no guideline that can tell us which treatment, when do we use. I think we have the luxury as a sports medical doctors that we have simply a weapon more in our arsenal that we can use. And I think for me it's more the indication where it's really working. The three cases I mentioned, there are other examples that go in that direction, and like anterior ankle impingement, where you really have an effective and sudden effect that works immediately. And then there are other situations like you mentioned, like tendinopathies. I think for me it's almost it depends really from the situation. This technique in the context of tendinopathy, if you have you do an ultrasound of we just had last week, last month, a patient with a quadriceps tendinopathy. It was mini. I had to take the T-stick to see the hypervascularization. It was a young BMX biker, and was already doing 4 months of therapy. She went once to Emanuele, treating this Rieder-Fokker of tendinopathy that wasn't visible with the normal linear sound, and it was resolved in 2 sessions. So I think you have to simply know where are they in the situation in which it really works well. And on the other situation, especially the complex one, I think it's as long as we do not have clear guidelines on how we can try. We have to be honest with the patient. We can introduce an adjunctive treatment that may or may not work, and go for it. At the end, it's an option more. A PRP, it's since many years a big thing in sports medicine. Everyone probably does it, but no one talks about it. And I think you can and should be open-minded about possible options. And I think this is an area, from my point of view, in my young experience, because I'm a young doctor, that has a really big potential. But again, you can believe or not believe.
I think this was a good closing statement of Daniele. I think you have to be curious, look at the methods. Of course, we all wish RCTs, but in sports medicine, sometimes the RCTs are coming a couple of years later. The aim should be not to harm the athlete. I think we all agree on that, and that the active therapy, the loading, and the active treatment is the main goal. But I'm really honest, when I looked at the slide, I miss a little bit the respect from some comments. And as Daniele said, the ones who made some comments, probably the ridiculous comments, they are not the ones who talk openly about new methods. So that's my closing statement for that, and I wish you a good lunch.